So yesterday we started with the electrolytes, okay, and then we understood some principles that we should understand the various compositions of the electrolytes in the various fluid compartments, okay. And then we also said that potassium was the most abundant cation in the intracellular compartments, whereas sodium is the most abundant cation in the extracellular compartments. And we also talked about the fact that these electrolytes are kept in their respective compositions, okay, with the help of the sodium-potassium pump. So the sodium-potassium pump is very key in ensuring the various compositions, okay, such that you have a lot of sodium outside and a lot of potassium inside the cell, okay. So today we are going to look at some of the abnormalities, okay. And the first abnormality that we are going to look at is with sodium abnormalities, okay. Sodium abnormalities. And the first abnormality we are going to look at is hyponatremia. So we said that the serum sodium level is between 135 and then 145. Okay, it must be between that range. Okay, usually we say if it's below 135, okay, you have hyponatremia. Okay, but some books use 132 or 130. Okay, so, and yesterday I emphasized that if someone comes with low sodium, okay, you have to repeat the sodium again and then rule out the solvent exclusion effect that we talked about yesterday. Okay. Now, there could be two reasons why the person's sodium levels are low. The first one is that the person has retained a lot of water and the water has diluted the sodium, reducing the sodium concentration. Okay, and then the second thing that can cause hyponatremia is when the person is actually losing sodium. Okay, the person is actually losing sodium. So we are going to take them one after the other and see how we can diagnose these. Okay, so the first one we're going to talk about is someone who has hyponatremia with water retention. Okay, so we have explained this, that if the person retains a lot of water, okay, the hyponatremia is called a dilutional hyponatremia. So it's a dilutional hyponatremia. That means that the excess water has diluted the sodium levels, okay. Good. Now, such people, okay, we can classify these people into two: those with the dilutional type, okay, or those with hyponatremia with water retention. We can classify them into two. We have those that will present with edema and those who will not present with edema. And yesterday, I was explaining what edema is, okay? And I said edema is when you have fluid accumulating in the interstitium. So for this one, we check it clinically, okay? And the way we check this clinically is to press any bony prominence, okay? Or press the skin against any bony prominence, okay? So maybe you can use your medial malleolus, okay? And when you press your skin against it, okay, you notice that it will come up. But those with edema, when you press it, you realize that you get a depression over there, which is called pitting. Okay, so this is how we check for edema clinically. Good. So those with hyponatremia, that is due to water retention, We have those that will present with edema, and then we check this clinically as I've described, okay? And we have those who will not present with edema. Good. So that has been explained. Okay. Now let's look at those that have edema. Those with the edematous type, okay? Usually is if you know the causes of edema, okay, these ones will be easier for you to understand, okay? For example, someone with heart failure, you know that there will be edema, or someone with liver pathology, such that the person cannot produce albumin, okay? The person can have edema, or someone with nephrotic syndrome who is losing a lot of proteins, okay? That person to have edema. So the water retention, which is caused by these clinical conditions I've mentioned, will lead to water retention. Okay, and this water retention is going to dilute the sodium, okay, and it will give them edema as well. Okay, so the causes of edematous hyponatremia are heart failure, and then any condition that will lead to hypoalbuminemia, okay, which is 1, liver pathology, and 2, someone with how do you call it? Someone with nephrotic syndrome, even someone with kwashiorkor, okay. All these ones, they appear edematous. Good. So they are saying that the treatment is fluid restriction, okay, and diuretics, okay. If you give diuretics, it's caused them to urinate a lot and then reduce the amount of water in their system, and then you treat the underlying condition. Good. The second aspect of it is the non-edematous one. Now, the non-edematous ones, okay, these are people who have water retention, and the water retention has diluted the sodium, okay, but clinically they don't have edema. When you check for the signs for edema, they don't have it, okay. And this one, the pathophysiology is those with the condition we call syndrome of inappropriate ADH release, okay. And this syndrome of inappropriate ADH release, okay, is when yesterday we looked at the function of ADH. So if you have a lot of ADH being produced, you notice that you are going to absorb a lot of water at the collecting ducts of the nephrons, okay? And that excess water is going to dilute the sodium. Okay, good. Now you have to know causes of syndrome of inappropriate ADH release. And then yesterday we looked at some of the stimuli for ADH release, okay? We saw that pain was one of them, nausea was one of them, hemorrhage was one of them. So all these things, if not controlled, can lead to excess ADH release. Okay. Please, is this point clear?
Have you written it?
Yes, please.
Okay, good. But there are some other conditions so that can cause inappropriate ADH release, okay? And one of them is so from this side, okay, so from this side of the slide, you notice that they said injuries or operations. So for post-surgical patients, okay, you have to be very careful with the amount of water you are giving them, because they are at risk of syndrome of inappropriate ADH release. Then cancers, people with liver cancer and then colon cancer too, they are also at risk of this, okay? And then some infections like pneumonia and then encephalitis, infections of the brain and then the lungs can also trigger ADH to be released, okay? Then some other drugs, okay? And then the things we talked about, pain, nausea, they can all lead to inappropriate ADH release, okay? The treatment is almost the same. Okay, good. So we are looking at hyponatremia, and you've seen that there are two possible causes of hyponatremia. Okay, the first one is when you have water retention. So the excess water will dilute the sodium. And with this part, there are two classifications over there. Okay. The first one is those that will present with edema. Okay, and then we said the causes for that one is people with heart failure, people with liver disease, people with nephrotic disease, kidney disease. Okay, they present with the edematous type of hyponatremia, which is caused by water retention. And the second one is the non-edematous one, which is as a result of syndrome of inappropriate ADH release. Okay, good. So now we are done with the water retention one. Now let's go to the ones which is due to sodium loss. Okay, so here you can see a picture of the edema I'm talking about. So when you press the person's skin against any bony prominence, okay, you see that it will pit. This is what is called pitting. The depressed area is what is called a pitting. This simple test can just classify people into edematous and a non-edematous. Okay, very simple. Good. So now, how can we lose sodium? Okay, so the commonest way of losing sodium is through the kidneys. Okay, so you can lose sodium through the kidneys. You can lose sodium through the GIT, and then you can also lose sodium through the skin. So someone who is sweating a lot, you know, sweat contains a lot of sodium. So if you sweat a lot, you are going to lose the sodium, and then that can lead to hyponatremia. Okay, and then GI losses, someone who is vomiting or someone with diarrhea. Okay, all these can also make them lose sodium. And then the most important cause of loss of sodium is the kidneys. Now, yesterday, if you remember, we said that aldosterone is a hormone which aids in the reabsorption of sodium at the expense of potassium and then hydrogen, right? I'm sure you remember that. Good. Now, if you have a situation where you are not producing aldosterone, okay, like a condition like Addison's disease, which is called adrenal insufficiency. When you have this condition, you are not producing aldosterone. So in this case, you cannot reabsorb the sodium. So when the sodium gets to the collecting ducts or the distal convoluted tubules, it will just pass into the urine. Okay. So in this case, you lose a lot of sodium. So not only Addison's disease, but if you are also using drugs, okay, there are certain drugs which is used to treat hypertension. Now, I'm sure you guys know that if you reabsorb more sodium, okay, you have a lot of water in your system, and that can lead to hypertension. Okay. So some of the drugs that we give for hypertension, what they do is that they inhibit sodium reabsorption. Okay. So some of them antagonize aldosterone. Okay. Yes. Someone's hand is up. Do you have a question? Okay.
Please,
okay,
can you take it again?
Okay. Yeah. Okay, I'll take it again. So what I'm saying is that one cause of hypertension, okay, one cause, I'm sure you guys have done Cushing's disease, okay, but I will take you guys through again. You notice that Cushing's disease, they have excessive mineralocorticoids and then the glucocorticoids, okay, and then those ones have aldosterone effects. Okay, or if you have a condition like Crohn's disease, where you are producing excessive aldosterone, what's going to happen is that it's going to make you absorb more sodium, okay? And if you absorb more sodium, you also absorb more water, and that will increase your plasma volume and then cause hypertension. Okay, so some of the drugs we give are drugs that inhibit the effect of aldosterone. Okay, so those drugs inhibit the effect of aldosterone. So if you are giving people this kind of drugs, they are prone to getting hyponatremia. Is it clear? Someone's hand is up. Do you have a question? Or Okay, I'm sure you guys understand. Let's continue. So we are done with hyponatremia. So we can group hyponatremia into two. Okay, dilutional hyponatremia, and then the ones which are caused by losing sodium itself. Is it clear? The dilutional one, we can group them into two. The one which will present with edema, and the ones which will not present with edema. The edematous ones are the heart failure, and the heart failure, and then the kidney disease, and then the liver disease. Okay? And the non-edematous ones are the causes of syndrome of inappropriate ADH release. Then we talked about the actual losses of sodium, which includes GIT losses, skin losses by sweating, and then renal losses. Okay, and under the renal losses, we saw causes like Addison's disease, and then certain drugs or medications. Okay, good. Now let's go to how do we treat these patients? Okay, so this one is very simple. Okay, you can give them sodium, IV fluids, 0.9 normal saline. Okay, and then you treat the underlying cause. Good. Now let's go to hyponatremia. Hyponatremia is when you have your serum sodium level exceeding 145 millimoles per liter. Okay, but I mean, some people use 148. Okay, so you can use the 148. It's in your slides. Good. So what can cause hyponatremia? This one too, they are basically two things. Okay, basically two things. It's just like the opposite of the hyponatremia. So one is water depletion. So in this case, you are losing water. Okay, and then the second cause is when you are actually gaining salt, like you are increasing salt intake. Okay, and then there's a third one. Okay, which is this case you are losing both water and salt, but you are losing the water more than the way you are losing the salt. So in this case, the concentration of the salt will be high. Okay, so that makes it three. So the first one is pure water depletion. So that one you are only losing pure water. Then the second one is when you are losing water and salt, but you are losing more water than the way you are losing the salt. And the third one is when you are actually increasing sodium intake. Okay, so these are the three causes of hyponatremia. Okay, good. Now let's look at the first one, which is the pure water depletion. So for the pure water depletion, okay, pure water depletion. So that one, the first cause is failure to take in water. When you don't drink a lot of water, you can have this pure water depletion. Or when you are losing only water. So there is a condition called diabetes insipidus. Okay, so diabetes insipidus is when the ADH is not working. Okay, so there are two causes of diabetes insipidus. The first one is the central cause. For the central cause, that one you are not producing the ADH at all. Okay, and you have the nephrogenic cause. For the nephrogenic cause, you are producing the ADH, but it cannot work in the renal collecting ducts. Okay, so those are the two types of diabetes insipidus, the central one and then the nephrogenic ones. Okay, so these are the causes of pure water depletion. One, you are not drinking the water at all, and two, you have diabetes insipidus, either central or nephrogenic. Okay, good. Now the treatment is that just give the person water. Okay, and then if the person is unconscious, you give the person IV fluid with 5% glucose. Yesterday I mentioned the need for the IV glucose. Okay, I said that when you give them IV glucose, will be metabolized in the cells and give extra water. Okay, good. Now the second cause of hyponatremia, that is high levels of so we said there are three causes of hyponatremia. The first one is when you are losing pure water. So when you lose pure water, okay, the volume of water reduces, and hence it will make sodium appear concentrated. Okay, so the first cause of hyponatremia is pure water depletion. And under the pure water depletion, there are two causes. One is when the person is not drinking water. Okay, and someone will ask, why is the person not drinking water? Okay, and then we said that some people don't drink water because maybe they don't have water at their place, or someone who is unconscious, the person cannot drink water. Someone who has been admitted in the hospital. Okay, good. Then the second cause of pure water depletion is diabetes insipidus, which could be central or nephrogenic. The central one means that you are not producing ADH, and the nephrogenic ones means that you are producing the ADH, but it is not working in the renal collecting ducts. Okay, good. Then the second cause of hyponatremia is a case where this time you are losing water and salt. Okay, and so you are even losing sodium, but you are losing more water than the sodium. Okay. And then we see this case in vomiting and then diarrhea. Okay, so note that when someone is vomiting or having diarrhea, the person can have either hyponatremia or hypernatremia. Okay, but you see, whether it will cause hyponatremia or hypernatremia, it depends on how much of the sodium you are losing. Okay, so if you are losing more water than the sodium, then you have hyponatremia because you've lost a lot of water. Okay, you've lost a lot of water, and you are also losing sodium, but you are losing the sodium at a lower rate. So in the person system, you have concentrated sodium. Okay, so this point is very confusing. Okay, this point is very confusing. And then the second one is when you are sweating a lot. When you are sweating a lot too, as we saw, it's a way in which you lose sodium because sodium is lost through sweating. Okay, so why doesn't it cause hyponatremia? It doesn't cause hyponatremia because this same person is also losing a lot of water as compared to the sodium. Okay, so the fact is, if I am sweating and then I'm not losing a lot of water, but I'm losing a lot of sodium, then I'll get hyponatremia. But if I'm sweating and then I'm losing a lot of water as compared to I'm losing sodium, then I'll get hyponatremia. Okay, good. Now the treatment is the same. The treatment is the same.
Senior Bright,
Yes.
please, if you are sweating, what determines whether you lose salt or you lose water?
Yes. So it depends on the severity, okay, of the heat. Okay, it depends on the severity of the heat. If the heat is more severe, okay, then that one you lose a lot of water. Okay, so it's dependent on the condition. Okay, you don't determine it. Okay, it depends on the environmental factors. Okay.
Okay, thank you.
Oh, welcome. So we've looked at causes of hyponatremia. We've seen that one, it can be as a result of water. Okay, it can be as a result of water depletion. Two, it can be as a result of both water and salt depletion, but in this case, you are losing a lot of water as compared to salt. And the third cause of hyponatremia is when either when you increase your intake of salt, like someone who is with a lot of salt in it, or someone who reabsorbs a lot of sodium at the renal nephrons. Okay, so you notice that we said aldosterone is for renal, for sodium absorption. So if someone has a condition where they have high levels of aldosterone, then they will have a lot of salt because aldosterone will reabsorb the sodium. Okay. So all the conditions that can lead to high aldosterone levels or high mineralocorticoids or glucocorticoid levels can cause high sodium or hyponatremia. So examples includes Conn's disease or Conn's syndrome, which is high levels of aldosterone, or Cushing's syndrome, okay, where you have high levels of glucocorticoids and then mineralocorticoids. All those things can lead to reabsorption. Okay, so we have Conn's disease over here, and we have Cushing's syndrome. And then sometimes for children, okay, when you are giving them IV fluids of sodium, of how do you call it, normal saline, which is sodium and chlorine, and you don't monitor it, you can give them excess. Okay, good. So we are done with sodium. We've talked about hyponatremia and hypernatremia. Okay, we are done with those ones. Good. Let's look at anions. Okay, let's come to anion. Now, sodium goes with chloride. Okay. Now, for chloride, I said that chloride is the most abundant anion in the extracellular compartment. Okay. But usually chloride doesn't give us a lot of problems. Okay. Most of the problems are from the cations. Okay. The anions usually don't give us a lot of problems. But I want to introduce a concept over here, which is very important, which is called the anion gap. Now, this is the principle of the anion gap. Now, the fact is that, okay, the cations must be balanced by the anions so that we have electrical neutrality, okay?